Afternoon. It is exactly noon, which means it's testicular pain time. I'm Amy Pearlman, urologist and men's health specialist. You know, the title of our talk today, it's a little bit misleading. It states the evaluation and multidisciplinary management of chronic testicular pain. Now, that is all true. That is what we will discuss over the next 30 to 45 minutes. But in a nutshell, makes it sound like it's we can simplify this, but in reality, it's actually quite complicated. And I think at the end of this talk, we're actually going to find out some additional questions that need to be answered, and perhaps that we actually know a lot less than what we think we know about testicular cancer. But that's okay. I think we're moving in the right direction. We have no relevant disclosures. At the end of this session, you'll be able to outline a physical examination, list a differential diagnosis, implement a hip-focused evaluation, discuss treatment options, and most importantly, perhaps, is we'll brainstorm some ideas for future research. Now, the patients that I'm talking about in this presentation, they're not the testicular torsion patients. They're not the acute bacterial epididymitis patients. So those patients typically don't show up in my office because they've shown up to urgent care or their primary care doctor or the ER, and they're diagnosed with those issues. They get an ultrasound, shows no flow. They go right to the OR, or they get antibiotics and they get better. So I'm talking about the young active man who comes in with chronic testicular pain for which we have no obvious cause. Patrick Walsh recently gave a presentation and he stated this quote: "If you want to make an important discovery, listen to your patients." Emily, can you hear me okay? Is there a lot of, yeah? Okay.
Yeah, I can hear you.
Okay, great. So let's listen to our first patient. This is John. He's coming in to see me Wednesday at 8 a.m. He's a 38-year-old male with intermittent bilateral kicked in the nuts testicular pain for 3 months that radiates to his lower abdomen. He also reports urinary intermittency and straining, occasional penile burning. He also has bilateral intermittent hip pain. Now, as most of our patients, he's not reporting this to me. These are questions that I'm asking him specifically about his urinary symptoms and about his hip pain, but really his main concern is this bilateral testicular pain. He also reports some low back pain, and he thinks that his pain may be related to a stiffer bed. He states that his pain is worse with standing, sitting, lying, bending, shifting weight from side to side, so pretty much with everything. And his past medical history is significant for HIV, anogenital, HSV. He's seen a chiropractor before for thoracic pain that he has had since he was 12 years old, and he is bisexual. What next? All right, well, let's start with the physical exam. That's obviously an important part of this whole thing, history and physical. And we'll talk about what that abdominal exam looks like and what the genital exam looks like, going through the external genitalia, looking for a hernia, as well as a perineal, a rectal, and a pelvic floor exam. In order to really understand the exam, we have to understand some of the basic anatomy. So I'm going to take everyone back to the anatomy lab, cadaver lab, first year, gross anatomy. You know, Emily was there just a year ago. We're going back to the basics, folks. Let's talk about nerve innervation. First, we have the iliohypogastric nerve that comes from L1 that gives sensation to the lower abdomen. Then we have the ilioinguinal nerve that also comes from L1, and that gives sensation to the mons and the anterior scrotum. And then finally, we have the genital branches of the genitofemoral nerve that comes from L1 and L2, and that gives sensation to the anterior scrotum. So when we talk about innervation to the lower abdomen and the scrotal contents, it is complex and does not come from a single nerve. And then as part of the exam, we'll move on to the scrotal exam. So we first examine the scrotal skin. We're looking for overlying erythema. Now, if there is overlying erythema or skin changes, I mean, those are the patients that I'm concerned, okay, this patient has a cellulitis, or maybe this patient has an epididymoarchitis, but most of the patients that I see in the office actually do not have any overlying skin changes. I'm also assessing for a retractile testicle because that may give me some more information about whether that cremasteric muscle is hypersensitive. And then I'm going to palpate the testicle for any masses, the epididymis for any cysts or any abnormalities for point tenderness, and the vas deferens as well. And I'll assess for a varicocele. Moving on to the hernia exam or the groin exam. We will assess for a direct hernia, so that's coming through the floor of the inguinal canal, and then assessing for weakness in the floor of the transversalis fascia, and for an indirect hernia, which is protrusion through the inguinal ring, which parallels the spermatic cord. So this anatomy is important, the groin anatomy, and as urologists, we don't oftentimes fix hernias, but we really have to go back again to these basics of the nerve. And the ilioinguinal nerve, as we know, if we're doing, orchiectomies for cancer, runs right in this inguinal canal. Now, we don't know the mechanism by which men who come in with hernias, like why they have pain. Is it the pressure of that bulge that puts stretch on the ilioinguinal nerve? Is it inflammation, irritation? But just by looking at the anatomy and the proximity, we can see how that hernia may cause an irritation or affect that ilioinguinal nerve and perhaps radiate pain to the testicle. And now moving on for the perineal, rectal, and pelvic floor exam, I think we all appreciate as urologists that both men and women have pelvic floor muscles, and that area is very complex. And whenever we do surgery on the male external genitalia, we oftentimes cut through this tissue. First we're just looking at, and we're examining the perineal skin. Now, when we have actually 4 pelvic floor physical therapists at the University of Iowa, and when I first was introduced to each of them, and I said, ladies, how do I test to see if my patients have pelvic floor dysfunction? And, they kind of initially instructed me to just kind of feel in the area, and it's way more nuanced than that. And so, they do a much more nuanced and subtle job of testing each of these muscles. But in terms of in our urologist's office, we're going to examine the perineal skin. We can palpate the perineum for point tenderness, inspect the anal opening, and then palpate the prostate and the rectal wall. So let's get back to our patient, because my patient, John, he's still sitting there and he's like, all right, doc, let's move this along. Let's see what his physical exam findings show. So his BMI is 21, not overweight. He's got an orthotopic and patent urethral meatus, no lesions, no discharge, and he's got bilateral testicles of normal size and consistency. He's got possible bilateral inguinal hernias on repair, and I do not appreciate any varicoceles. So let's summarize. So far, I have a 38-year-old male. He's coming in with intermittent bilateral testicular pain, also with hip and low back pain on further questioning. His history is significant for HIV and HSV. Physical exam is notable for normal testicles and possible bilateral inguinal hernias. This sort of assessment now necessitates further workup. So let's talk about what labs we may get based on that assessment. Well, we get a UA, and that's negative. We get a gonorrhea, chlamydia, also negative. So what imaging do we want to get? Well, let's start with a scrotal ultrasound, which shows a small right epididymal head cyst. Anything else? Well, on physical exam, I thought that I palpated some hernias, so let's just throw in a limited abdominal ultrasound. And he has a tiny reducible fat-filled right inguinal hernia. So we look at this paper, and this was a great paper written by one of my colleagues, Alex Tatum, and this goes over the treatment options. And you look at this chart, and wow, there's a lot of information on there that it puts poor Dr. Pearlman in fetal position. So let's break down this chart to make us feel a little bit better, and perhaps we can guide our patient through this process. So we performed the initial investigation. That's our history and physical exam. Optional ultrasound, urinalysis, urine culture. Okay, we got that, nothing super remarkable on that. And then in terms of conservative management, so we have dietary changes, tight underwear, compression shorts, ice, avoid activities that evoke pain, avoid prolonged standing. So for those of you on the call, look through those things. I mean, we've all given those recommendations. We tell our patients, all right, bro, wear compression shorts, ice the scrotum, get a frozen bag of peas, and limit your activity. But, when we think about who these patients are in our office, they're oftentimes these young, active gentlemen who are maybe construction workers, or, they have busy family lives, and those things just simply don't always work. And, the compression shorts can worsen pain, although sometimes they can also improve pain. But we've certainly told all of our patients to elevate and ice. So this is the left side of that busy chart, and we're going to go down here. So for pathology that's identified that is directly related to the pain, so our patient had a small epididymal cyst, all right? So how do we know if that small cyst is causing his pain? I think we've all been involved in these procedures where we remove cysts for pain before, but we really have no idea of knowing whether or not that improves their pain. I think we've also seen plenty of these patients who we've done surgery on who still have pain despite removing part of their epididymis. And then, he's also coming in with this reducible fat-containing hernia. And so is the hernia causing his pain? Well, gosh, I don't know. And this algorithm actually doesn't give us any guidance on how to say whether or not these issues are causing the pain. And yet their treatments are surgical. Now we're going to move to that right part of the diagram. So this is for when no identifiable pathology is noted on physical or imaging. So the next part of this is rule out extrascrotal causes of pain and obtain relevant imaging and or consultation. So just ask yourself for a second, what does that mean? What does, extrascrotal causes in terms of like the entire body? What are we talking about here? And what is the relevant imaging? And what is the relevant consulting practices that we should follow? And then, going down this chart too, so we have, all right, history of epididymoarchitis. Well, sure, a lot of these patients come in with chronic pain. They've been diagnosed with epididymoarchitis before, but was it just testicular pain or was it a true infection? So how do we know when to start an antibiotic, or how many courses does somebody have to fail before we say, okay, I don't think it's infectious in nature? And then when we look at all these other medications on this list, well, Flomax, do I give Flomax to someone who also has urinary symptoms? What if they're just coming in with testicular pain? Gabapentin, Lyrica, amitriptyline, all of these are going to have, they all play a role, but they all have potential side effects, especially for our young active guy who really can't lead his normal life if he feels drowsy during the day or his GI upset. And then we're talking if he has a prior vasectomy, are we doing a vasectomy reversal? So that's all cash out of pocket, might be cost prohibitive. And then, all the way down here on the bottom of this algorithm is consideration of referral to pelvic floor rehab. And then let's look at this other option here, which is what we as urologists, after perhaps antibiotics, ice, elevation, anti-inflammatories, we might go the route of the spermatic cord block, right? This is well within our wheelhouse. And the recommendations are 2% lidocaine plus some bupivacaine. And if there's no relief, then referral to the chronic pain specialist. But who is the chronic pain specialist? And what are they actually providing to our patients? And then when do we offer, a cord denervation and orchiectomy, and how do we predict who is going to get better from those procedures? So to go back to that initial point that Patrick Walsh made, he stated, again, if you want to make an important discovery, study something that few others want to study. Now, the second part of that line is by our very own chairman of urology at the University of Iowa, Carl Creeder. Now, so in studying testicular pain, I see a lot of these patients in my office, and I really feel confident in saying that I don't think any of my partners at the University of Iowa have any issues with me seeing the patients for testicular pain. So let's go back to that drawing board and see what questions we can brainstorm, what we know, what we don't know about these patients. We're talking conservative management. Here's a question. So for dietary changes, would eating an anti-inflammatory diet improve chronic testicular pain? We know when we see patients with chronic, with bladder pain, chronic pelvic pain, interstitial cystitis, we oftentimes talk about anti-inflammatory diets and dietary changes. Well, would this prove beneficial in our testicular pain patients? It's funny, when I was seeing a few gentlemen recently for testicular pain, I asked them as a urologist, sir, walk me through what you typically eat on a daily basis. And I think that takes them a little bit by surprise because they're not expected to have that conversation with their urologist. Perhaps my sister, who's a gastroenterologist, they would be, ready for that conversation. But it was funny because, one of the guys, the first thing out of his mouth was, I eat a lot of broccoli. And I just wanted to be like, sure you do. I asked him, oh, hold on one sec. Can you hear me? Okay, sorry, sometimes it mutes. So I asked him, well, tell me, how much meat do you eat? And he said, oh, yeah, doc, I eat a lot of meat. And I'm like, how much dairy do you eat? And he's like, oh, yeah, I eat a lot of dairy too. So this guy's eating a lot of actually pro-inflammatory foods. And so before I counsel him to say, you got to really knock down the meat and the dairy, well, we first have to know if that's actually good advice for me to give that person. All right, let's talk about the hernia group. So here are some questions for everyone. In patients who present to the general surgeon with inguinal hernia and ipsilateral testicular pain, which of these men experience resolution of their testicular pain after inguinal hernia repair? Another question, can we predict which men will benefit from inguinal hernia repair by performing an ilioinguinal nerve block prior to hernia repair? So we've all seen these patients who are coming in with groin pain. Perhaps their pain radiates to their testicle. When we go through their life history map, we map that out. They've had prior hernia repairs before. And actually a high percentage of these patients who have had hernia repairs come in with chronic groin pain, and they're sent to our pain management colleagues and they undergo perhaps iliohypogastric and or ilioinguinal nerve blocks. But perhaps we can predict those who will benefit by doing that block before the hernia surgery rather than after the hernia surgery. All right, and then in terms of ruling out this this vague extrascrotal causes of pain and obtaining the relevant imaging and referrals, how do we assess for hip pathology in those who present with chronic testicular pain? We know that we need to, but how is it done? And then when we consider referral to pelvic floor rehab, well, which patients will benefit from pelvic floor physical therapy? And can we predict those who will benefit based on the baseline pelvic floor exam? And then just going back to some of the work that's been done in the musculoskeletal field, would transcutaneous electrical nerve stimulation using TENS units improve pain? Sorry, let me just move this here. Oh. Okay. And then finally, for our spermatic cord pathway here, and for the pain specialist. So for those who are referred to the chronic pain specialist, which patients would benefit from seeing the pain specialist and having an interventional procedure with the iliohypogastric and or ilioinguinal nerve blocks? And finally, for those who undergo the spermatic cord injection, would blocking this area with an anesthetic plus a steroid, so our orthopedic colleagues and our pain management specialists, they use just the local anesthetic like Marcaine lidocaine for diagnostic purposes, but when they're treating the pain, they oftentimes add in a steroid. Now that steroid can cause a paradoxical effect initially where it increases pain, so you wouldn't use that for diagnostic purposes. But perhaps if we're thinking about doing these injections, every few weeks to see if that changes this pain pathway, then would blocking the genital fibers with an anesthetic plus a steroid result in more sustained pain relief? And these patients who present to me with chronic testicular pain, they're really part of our chronic male pelvic pain patients. And testicular pain and the inguinal region pain are just part of that sort of disease process. So the question here is, what can we learn from the chronic pelvic pain patients who also have testicular pain? And when you put all of those red boxes and question marks all together, I mean, it pretty much fills the screen with the unknowns. But everyone on the call, I want you to look really closely, and you see kind of a white light in there. There is a light at the end of the tunnel, and we've started to make some progress. So let's go back to where we started making progress in our work, and we're going to go to the extrascrotal causes. And trying to address this question of how do we assess for hip pathology in those presenting with chronic testicular pain, AKA when testicular pain became an orthopedic problem. Emily, you're up.
Okay, thank you. My name is Emily Salzrud, and I'm a second-year medical student here at Carver. I'm interested in going into orthopedics, and so originally this summer I thought that I was going to be working in the orthopedic clinic. However, my research mentors, Dr. Pearlman and Dr. Brown in ortho, tricked me into studying testicular pain this past summer. So my project was on assessing hip pathology in patients presenting to the urologist with orcalgia. Now, our orcalgia can be difficult to treat, and it often has an unidentifiable etiology. Hip pathology is rarely assessed in the urologist's office. So the aim of this study was to evaluate these patients presenting with orcalgia for hip pathology. So we included in the study men presenting to the urology clinic with unilateral or bilateral orcalgia. We offered them hip-specific questionnaires, and we performed some physical exams on them, including provocative testing and range of motion exams. We then obtained x-rays, including an AP pelvis and done laterals for both hips. These are some examples of the provocative tests that we performed on the patients, featuring my brother and my dad. So on the top left, we have the straight leg raise, which is assessing for sciatica. And then we have the other three exams, the Stinchfield impingement and the Patrick's test, that are assessing more intra-articular pathology. So when we're doing these exam maneuvers, we're asking the patients, where do you feel the pain? Or I guess, first off, do you feel any pain? And if so, where? And we ask them if they feel pain in the groin, in the hip, or if it reproduces their testicular pain. Back to our patient. On the right side, he had a positive Patrick's test, but was negative for all other provocative exams. And then on the left side, he was positive for all provocative exams. Next, we obtain radiographs, and these are examples of the analysis we do on the radiographs that we obtain assessing for hip pathology. We look at the alpha angle, the lateral center edge angle, the crossover sign, and the tonus angle. Our patient had minimal symphysis pubis DJD, but did not have any signs of hip pathology on X-ray. In our study, we enrolled 50 patients with a total of 100 hips. We had a mean age of 41 years and a mean BMI of 29. For provocative exams, we tested 37 hips positive for impingement test, 29 positive for Patrick's test, 21 for Stinchfield, and 2 positive for the straight leg raise. About half of the hips had findings of osteoarthritis, over half had findings positive for acetabular dysplasia, and about a quarter of the hips were positive for acetabular retroversion and a cam-type impingement. While this wasn't the purpose of the study, based on physical exam and radiographic findings and a shared decision-making between members of the testicular pain, we identified 11 patients and referred them to orthopedics, and then 2 of these patients actually had an orthopedic diagnosis or intervention that relieved their symptoms. In conclusion, men presenting to a urologist with orcalgia may have underlying hip pathology, and we can use hip-specific physical examination and radiographs to help identify these men that may benefit from seeing a hip physical therapist or have an orthopedic intervention.
Awesome. Thank you, Emily, and thank you for all the work that you've helped in allowing us to do. I do want to make clear with this part of the presentation that our recommendation is not to refer every single man with testicular pain to orthopedics. You might make some enemies doing it that way. But, you know, what this study shows is that it's very easy actually for urologists in the office to do some provocative hip maneuvers and to get some x-rays. And then what I did after I saw these patients in the office is I sent a message to, you know, 5 to 10 people, depending on the patient's story, my, hip physical therapist, 4 pelvic floor physical therapists, orthopedic colleagues who specialize in arthritis and the young adult hip, and sometimes some other folks as well. And I presented the patient's symptoms and physical exam findings and x-rays. And then we decided based on that, which of those patients were going to be seen by a hip physical therapist and or orthopedic surgeon. But that's not really, we didn't test that in this study. So on this study, really what we can report are the findings of patients presenting with abnormal radiographic findings and provocative hip testing. So this study raises many more questions, which we will work to continue to answer with additional studies. So thank you, Emily.
Yeah, thank you.
So now what? Because my patient, he is still in the office. What do I tell him? Do I tell him, look, man, get a softer bed, elevate that scrotum, take some anti-inflammatories, let's try an antibiotic. You haven't tried that before. You know, do you want to try gabapentin, Lyrica, amitriptyline? Am I doing a spermatic cord block up front? And if he has benefit, will I offer a cord denervation? He's got that small epididymal cyst. Could that be causing his pain? Maybe. An orchiectomy? And then I'm thinking about referrals. So this guy came in, right? Like most of our patients, he's got other stuff going on. Testicular pain is not his only problem. So he did report, you know, the hip pain, the low back pain. So am I sending him to physical therapy? And if so, what type of physical therapist? Am I sending him back to his chiropractor that he previously saw for his thoracic pain? Am I sending him right to orthopedics to assess his hip? Or what about orthopedic spine? Because those are not the same orthopedic specialists. Or am I sending him to neurosurgery spine? Because, you know, ultimately pain, that's a nerve problem, right? Or am I sending him to general surgery? Because he does have that fat-containing hernia, and I did feel it on exam. So maybe it's doing something to cause his pain. So this is a depiction, wow, of our testicular pain team. Now, I'm excited to be on the team. I don't know how many of these people on this list are excited, but you know, we're all seeing the same patient. And it was funny because about a year and a half ago, I set up a brainstorming session with many members of our comprehensive men's health team at the University of Iowa. And I remember vividly the setup of the room. I'm standing up front and I see the young adult hip orthopedic surgeon, the arthritic orthopedic surgeon, some pelvic floor physical therapists, and many others in the room. And I made the following hypothesis. And I said, folks, I think we are all seeing the same young man in our offices. I think it just depends on a few factors. It depends on how that patient verbalizes his pain and the questions that we as providers ask that patient. Let me give you an example. 37-year-old male presents, you know, to urgent care, and that urgent care provider says, hey, Bill, well, what were you doing before the pain started? And he says, well, I was on the squat rack. I was making some gains on the squat rack. Where's he going? It's probably sports med, right? Maybe physical therapy. But let's say that same provider asks the patient, well, hey, Bill, where does the pain radiate? And Bill says that his groin pain radiates to his left testicle. You say testicle, and that patient is coming to us as urologists for a completely different workup and management plan. I don't think any orthopedic surgeon would be prescribing this patient with groin pain an antibiotic. And yet that has become a staple of our therapy as urologists. So it's really this groin pain patient that I think manifests in various different ways. If that patient says, well, it feels like there's a little bit of a bulge in the groin, I mean, that guy's going to general surgery for a hernia repair, and his pain may or may not get better after that. So looking at this team, let's think, where is this patient going to next? Ding, ding, ding. Amanda Paulson, hip physical therapist. Let's see what Amanda has to say to our patient. So patient goes to hip PT, visit number 1. On physical exam, the patient is found to have bilateral hip weakness, core weakness, global trunk range of motion deficits. He's tender to palpation over the lumbar spine, especially L3 to L5. She is able to reproduce the low back pain and bilateral hip pain, but is unable to reproduce the testicular pain. The plan: abdominal bracing, back stretches for low back pain, and continued PT. At time of hip PT follow-up, the interval history, patient reports significant improvement of his symptoms when compliant with the home exercises, and now reports only mild residual testicular pain. So now on my team, he's still got some mild residual pain. Where's he going to next? Ding, ding, ding. One of 4 of our pelvic floor physical therapists. So patient goes to pelvic floor PT and on physical exam is found to be tender over the anterior pelvic floor, the right iliopsoas, and is non-tender to the inguinal ring, to the inguinal canal bilaterally. So their plan is to address pelvic floor in addition to the prior hip exercises to continue PT every 4 weeks until 70 to 80% improved. So, I'm really nowhere in this process. A lot of patients come to me because they feel pain in their testicle. And I certainly do offer spermatic cord blocks and spermatic cord denervations. But that's the minority of patients actually that I put through surgery. So one of my colleagues, Brett Erickson, said something to me very interesting recently as I thought very artistically tried to elaborate all of these questions and all these projects that my team and I are working on with these patients. And a lot of them are interventional studies or prospective studies. And he said, Pearlman, I think, you have the cart in front of the horse, and perhaps we don't even know what the natural history of chronic testicular pain is. And so you really got to look at that as well. So we know, why some of these interventions may or may not work. So with that, this is my sort of depiction of dropping the mic. We're going to drop the ball here. And that's all Emily and I have today. We appreciate your time this morning, and we will take any questions, comments, and or grievances through the chat box, or you can take yourself off mute. And I will not accept 0 responses. I want to know, what do you wonder? What are the questions that you have? Do you think this is all bull? Let's hear it. We can take it. No one. Bueller.
Dr. Pearlman?
Hi.
My name's Jack Dahlheit. I'm a urologist. Can you hear me?
Yes, I can hear you.
I've been in practice about 30 years. I've seen numerous orcalgic patients. Never have I seen one develop anything serious, which is their main concern. Is this a malignancy? Mm-hmm. Have you ever seen or heard anybody that said, oh yeah, by the way, if they felt a normal testicular exam, that they found anything that was life-threatening or life-changing other than the chronic pain? I've done the cord blocks to some success periodically. I've made referrals to orthopedic surgery, or at least our chronic pain management people who seem to have done well. The radiographic studies beside plain films, is there any role for MRI for persistent pain that you've seen?
Yeah, good question. Those are the tough patients. I find the toughest patients are those who have some mild pain, but that's not really why they're coming in to see us. And when I feel like I'm not making any progress in that office visit, sometimes I have to take a step back and I say, Bob, help me understand, what are you hoping to get out of today's visit? And what I hear in the response is, look, my pain is okay. It's there, it's present, but I can get through the day. I want a diagnosis. My mother was just diagnosed with breast cancer. She's BRCA positive. I'm BRCA positive, and I want you to tell me I don't have cancer, and I want a diagnosis for my pain. And what I said to a patient recently, after actually meeting with a pain psychologist and a pain pharmacist in terms of how they counsel patients, is I said to the gentleman, I believe that you're in pain. And he's like, yeah, I know that you know that I'm in pain. I know that you believe me. I want a diagnosis. And I said, your diagnosis is chronic pain. Now, Dr. Dahlheit, that's not a conversation that I think any of us have, ever learned to say to a patient, we're urologists, like we are surgeons, we want to find something wrong, and we want to fix it. But the problem is a lot of these patients, they don't have identifiable structural abnormalities. And I think what we have to do is outline what our role is on this team at that first visit when this chronic pain patient comes to see us in the office. And that conversation might look something like this. Hey, Bob, I'm Dr. Pearlman. I'm a urologist. I see men all the time with chronic testicular pain. My role on the team is to rule out structural abnormalities that I can, fix with either, surgery or infection. That's my job. But once I've ruled those out, then I have, 10, 15 other people that I potentially can send you to depending on the physical exam findings and your other symptoms. But I think as urologists, we want to do something. We're doers. And I think that's why we oftentimes go to the antibiotics and the anti-inflammatories. But I think we've missed the boat actually with this chronic pain. I think there's a lot that we can learn, not from our interventional pain specialists necessarily, but from our pain psychologists, from our pain pharmacists who actually can describe to our patients what that pain pathway looks like. In terms of imaging, what we found from this study, and we have to do a little bit more work in terms of the statistical work, but you can't just get the x-rays, because what we know in patients, not even necessarily presenting with testicular pain, but just people who get hip x-rays, is oftentimes they come back as abnormal. So when we first started doing these x-rays without the provocative hip maneuvers, they were all coming back as, concern for hip impingement, clinically correlate. So I reached out to our orthopedic colleagues and I was like, yo, Westerman, am I that good that I'm just picking up on all of the patients who have abnormal hip x-rays? And he's like, no, Pearlman, relax. You're not that good. It's actually very common. The question is whether or not it's clinically significant. That's where the provocative testing comes into play. So I think what we'll find out after we look through this data and sift through it a little bit more is that we actually don't need the x-rays. We can do it based on the physical exam findings. And I think the real question with the physical exam is, are the movements that I'm doing with your hip, is it reproducing the pain that you came to see me in the office today for? Because we can't simplify it so much as to say, well, it's either a hip problem or a pelvic floor problem. No, I mean, in a lot of these guys, it can be both. And if there's a hip issue, it might be causing a pelvic floor dysfunction. But the question about getting additional imaging with MRI, I mean, just in speaking with our orthopedic colleagues, we did, Emily and I did a presentation at Mary Greeley, and one of the orthopedic surgeons raised his hand in the back and said, why don't you just do, range of motion testing and this impingement testing and send those patients who test positive to orthopedic. So I think it might honestly be as simple as that. And so look out kind of as we sift through this algorithm and give urologists and primary care doctors easy things to do in the office to rule in or rule out these issues, so we're not wasting our specialists' time if they aren't actually going to benefit from seeing that specialist. Dr. Dolhai, does that answer your question? I know that was a very long-winded response. I'm passionate. What can you do?
But I guess the point is, I'll incorporate more hip exercise and provocative testing in the office. That's easy, simple thing to do. A lot of them complain of back issues.
Yeah.
And I presume that a lot of it is arthritic issues. Mm-hmm. And I try to tell them it's kind of like a sciatic pain. It's referred. It has nothing to do with the testicle. A lot of them are very happy with the fact that they don't have cancer of the testicle.
Right.
And that's especially the young guys, because they found out that their friend down the street has it. And then you'll see 6 or 7, people who have been associated with that guy come into the office because they've got they're sure there's something there. Mm-hmm. The reassurance is easy. The ultrasound is done routinely at the acute care and the emergency room. It never really shows anything significant. And I very rarely ever find that spermatoceles or epididymal cysts or hydrocele tend to be the etiology of the pain. It's pretty common they come back. You may repair a hydrocele and be very happy with it. But as long as if it's just the hip that's the issue, can you explain the pathogenesis of why the hip? Is it because of the pressure on the ilioinguinal ligament and that subsequently causes issues, or what's the direct correlation between the pelvis, or the hip, I should say, and the testicular pain?
Yeah, it's a really good question. The easy answer is we actually don't know. And that's why, I have to go back and really think about what this natural progression is. But I'm just going to flip through to one of these earlier slides. And if we just think about like the anatomy and the proximity, the hip joint is a very complex joint, and there's like 27 muscles that surround the hip, and the hip is attached to the pelvic floor. So if someone is having issues with the hip, then it can cause a pelvic floor dysfunction. I mean, that's our running sort of hypothesis. When I sit down and I do some of these seminars with our hip physical therapists and our pelvic floor physical therapists, and wow, that field is way more complex than I think any of us as urologists appreciate. There is so much that goes into their evaluation and treatment plan that when you hear how complex it is, it kind of makes sense that a hip issue can cause a pelvic floor issue.
One last question for me, at least. I hope somebody else is listening too besides just me. The denervation procedures, how successful is that?
Good question. I think it depends on the patients who are getting the cord denervation. So most people will say that if you get more than a 50% benefit of a cord block, then you can reasonably offer that patient a cord denervation. But I'm not seeing the denominator. So the patients that I'm doing cord denervations on, for the most part, I've tried to rule out all of these other causes. Now, some of these papers, in this algorithm that actually in that review paper, it talks about a review for chronic testicular pain, but it also goes through their technique for cord denervation. But I think a lot of people aren't necessarily ruling out these underlying hip issues, which I hypothesize might be some of the reasons why patients don't improve after a cord denervation. So I don't know. And I've also seen, because I've, for some reason, have taken a liking to these patients with chronic testicular pain, I see the patients who have failed cord denervation. And so those are the patients that, these studies are really after, is why do some people fail? Who are those patients? What are the other issues that we're missing? I've done over the last year and a half 4 cord denervations, and I haven't seen all of them back and follow up. One went to convalesce in Florida over the wintertime. His case was interesting because he had so many prior orthopedic issues. And when he came to see me, he also was having like some SI joint pain. So I referred him back to his orthopedic surgeon. Orthopedic surgeon did surgery. His back pain improved, but he still had the testicular pain. Now this guy has been legally blind for the last 4 to 5 years. I gave him a cord block in the office. And he reached back out to my office, and I had given him a sheet of paper to read on the way out, or just to have his patient education material. He reached back out and he said, "Dr. Pearlman, I am legally blind. And for 15 minutes after you performed that cord block, my testicular pain went completely away, and I could read that piece of paper you gave me. I haven't been able to read a piece of paper like that in 4 to 5 years." So immediately I sent a message to his ophthalmologist, and I'm like, I don't know what the connection is, but this is kind of crazy. So I'm hoping to add an ophthalmologist onto the testicular pain team. But I don't know why. I think in many patients, it might just be the genital fibers. That's why, we get good results with the spermatic cord denervation. But there are also a lot of patients that we don't help. And that's what this work is trying to figure out. Does that answer your question?
Well, kind of, yeah. I don't think I'll ever do a denervation, but the cord blocks have been reasonably successful. And I've had patients come back maybe 2 or 3 years later and say, "Hey, now I've got the pain on the other side.
Yeah.
Please give me another." And that's very rewarding. I tell them to call me, give it a week or 2 and let me know if it's coming back. If it does come back, they go to physical therapy or chronic pain management. I'll let them do the further radiographic studies and evaluation at that point. But
yeah.
It's been informative. I didn't really see the hip relationship, and of course we don't really have a true answer for it. But I'll follow up with that and be a little more aggressive, especially with the younger patients.
Yeah, and the thing too. Oh, you're welcome. And we think about the hip. So the question becomes, well, why doesn't everyone who has abnormal hip imaging, why don't they all have pain? Well, it's going to depend on that person's movement and what their daily activities are. So if that guy, you can have 2 young men with the same x-rays, but let's say one of those gentlemen, he's sitting down in a chair all day in front of a computer. Well, he might be sitting weird, right? Where he has abnormal range of motion in his hips. And maybe that's the guy who has pain, right? And just based on all those muscle attachments and everything, oh my God, the fascia and the muscles, it's so complex. And they're attached to the pelvic floor. When I ask my pelvic floor physical therapist, like, what areas do you really focus on? They look above and below. So they're looking all the way up to the thoracolumbar junction. And perhaps that's a way that we can look at, really assess the back issues. I mean, in these guys who also have significant back issues, I get the lumbar, MRIs, and, they always come back normal. But there's testing that our pelvic floor physical therapist can do to palpate actually like the thoracolumbar junction to see if that reproduces their pain. So that's another area that we'll look at. Again, how can we as urologists test the thoracolumbar junction in the office to see, does this person necessitate a back MRI? So more to come, but I thank you for all your good questions, Dr. Dolhide.
Yeah, keep doing those studies. Thank you.
You're welcome. I'm reading this chat box here. So Stacy Pearlman, let's see. Our local pain interventionalists do not seem to offer treatment for chronic testicular pain. After following the flow chart, are there urology clinics that perform somatic cord blocks in the office, or does it require fluoroscopy? Do you happen to know of any local pain specialists that are better than others at treating? So really great question. In terms of the spermatic cord blocks, there is no fluoroscopy that's needed for that, because that is to get at the genital fibers of the genitofemoral nerve, which is basically just picking up on the spermatic cord and injecting directly into the cord. For those who perform the ilioinguinal and or the iliohypogastric nerve blocks, those are usually done under ultrasound guidance, and those would be performed by the interventional pain management team. Now, that's a question that I had reached out to a year and a half ago, as I reached out to our neurosurgery colleagues and our pain management specialists. And I said, what procedures are you offering for these patients? Unfortunately, there hasn't been too much data to say that any neurostimulator or neuromodulation has been helpful for these patients, but there is ongoing work in that field for what we would consider to be visceral pain. In terms of the blocks, I think a reason why they don't do these super often is because they haven't had great success, but that's a retrospective study that we're actually going to be working on this summer, is looking at those men who have presented to the chronic pain management interventional interventional pain team to see, which of those patients can get better. Can we predict those patients? But yeah, I mean, when we send them to chronic pain management, one of the most beneficial things I ever did when I started here at Iowa is I personally met one-on-one with various specialists, and I sat down with that person and I said, hey, Dr. So-and-so, who are the patients that you can help me out with? What do you like to do in the office? Who are the patients that you like to see? And a lot of these interventional, pain specialists, they're not going to be the ones to manage the chronic narcotic prescriptions. That's just not what they do, and that's okay, right? But there are other people within that pain management team, and there are two people that I met recently who I think can be very helpful in terms of counseling our patients. One is a pain psychologist. So at Iowa, there are two pain psychologists that will sit down with our patients for 1 to 2 hours and talk with our patients about pain and coping with pain. And for some people, that is just going to be the treatment that might help them out. And I asked them, well, which patients would be candidates to see you? And the answer from one of the specialists was, I will see anybody. The question becomes, will the patient see me, right? But that's just another person in sort of our armamentarium that can help counsel our patients. And then we have another person who's a pain pharmacist, and her job is to go through all the medications, chronic pain medications of all these patients, and go through, and she can also give recommendations on additional medications. But it's really tough, and I would say the place to start would be to personally meet with these specialists one-on-one to say, what do you offer for these patients? How can we work together? But at Iowa, we do have a great group of people, but they're very nuanced. So you got to figure out, which one can answer specific questions. And we certainly don't want to waste the patient's time or the provider's time. So thank you, Stacy, for that wonderful question. In terms of, let's see, Dr. Rowe, wonder if you can touch on your follow-up timing, especially after initiating a new therapy. How do you handle the post-hernia repair patient who now has testicular pain? They have more severe symptoms in my practice, and general surgery loves sending these guys over. So in terms of new therapies and how I follow patients up, I usually do 3 months. There's no really science behind the 3 months. It's just typically just based on the access into my clinic. I see our pelvic floor physical therapist as being the how orthopedics sees their pelvic floor physical therapist. And my one of the big things that I'm working on right now is integrating our pelvic floor physical therapists into our practice as urologists. I mean, as urologists, we are pelvic floor or pelvic surgeons. So of course our pelvic floor physical therapists, they really should be seeing the majority of our patients. I mean, our patients who are presenting with urinary frequency, urgency, any sort of genital pain, any sort of sexual dysfunction, erectile dysfunction, premature ejaculation, all those patients would benefit from seeing a pelvic floor physical therapist, and the pelvic floor physical therapists want to see those patients. In terms of, so what I'll do is I'll have them see the pelvic floor physical therapist for 3 months or 6 months, and then I'll follow back. If they're coming from far away, I'll have them send a message to me electronically. I also, having that good relationship with the pelvic floor physical therapist is so critical, because I may send the patient to pelvic floor physical therapy. Now, I try to set the physical therapist up for success. So if my patients are coming in and they've had pain for, let's say, all right, 2 months, then I'll say, well, you haven't had pain for that long. So, we'll give pelvic floor PT, some time to take effect, but you're not going to notice benefit even within a few sessions, and you have to be compliant with the exercises at home. Those are the patients who get better. But let's say you have another guy who's been having pain for 10 years. Well, I will say to that patient, the longer you've had the pain, the longer it will take for pelvic floor physical therapy to actually have an effect. So it's setting our pelvic floor physical therapist up for success. And also my pelvic floor physical therapist will very commonly reach out to me and say, hey, I've seen this patient on multiple visits. He's not getting better. Can I send him back to you? Yes. And then I coordinate that visit at that time. It's always hard to know exactly when to have the patient come back. And that's where that relationship with the pelvic floor physical therapist saying, are things getting better? Are they not getting better? Should we expect progress by now? If not, let's see him back. Let's go back to that drawing board that we previously discussed. Dr. Rowe, does that answer your question? Oh, and then one more question. So in terms of the groin pain patients, those are tough patients. As I delve more into the research of the groin hernia pain patients, I mean, a large percentage of those patients have chronic pain, and they're tough patients. And I think a lot of them, yes, they get sent to us and they get sent to pain management. And so I think the only way that we can intervene and lower the number of patients that suffer from chronic groin pain is to go back to that initial patient presenting who has all of the same symptoms that this patient had that we described in this presentation, and going back and asking ourselves, is this hernia actually causing the pain, or is it something else? And maybe doing fewer hernia repairs, so that we can minimize those number of patients who are still having chronic pain after hernia repair. And because with that hernia repair, you can still get the genital fibers of that genitofemoral nerve. Perhaps that's why they then have testicular pain afterwards. So I think it's going back to what is the natural history of testicular pain, what is the actual underlying cause, and not doing the cord denervation or the hernia repair or the spermatocoelectomy or the arthroscopy for the hip if that's not actually the reason that's causing their pain. Dr. Rowe, does that answer your question? Bueller? No? Yes, maybe.
Anybody? Does, yes, it does. Okay. I was trying to type. I couldn't get it to it fast enough.
Yeah. It's the testicular pain is simple and it's wildly complex, and I can only hope that my career becomes sort of like knocking down each of these problems and questions that we face when it comes to testicular pain. I'm excited about this field. I'm excited that I have all of you on this call, and I think we can, in a very real way, work together to help crack this nut, so to speak. No one's laughing. Tough crowd this morning. Emily, where are you at, girl? I need some laughter here. Nothing. All right. So it's been about an hour. Let's see. Will this presentation be accessible afterwards? Yes, Stacy, it will be accessible. Well, thank you everyone for tuning in. This was really fun. And, as you see patients in the office, at Iowa, we just have a lot of resources here. And so I'm happy to talk through some of these patients if I can be of any service to anybody in trying to tackle these very complicated patients. We appreciate your time. And y'all stay safe and stay healthy. We'll see you on the flip side.
Perfect. Thanks, everybody.